Boo boo. Hello.
Hey, Gerald, how are you?
Yeah, not too bad. You?
Doing all right. It's the end of a work week for me, at least. So,
Yeah.
yeah, at least a full time, and then I have my internship tomorrow. But yeah, I'm looking forward to this one. There's a lot of people signed up. So,
Oh yeah, we had that one at the end there too, so that's good.
yeah, and I think a couple of them, if I remember, if I look at the list, I think some of them are even from outside the United States. So I thought there was one from United Arab Emirates and then one from Egypt that was going to be attending or something. So
it's super dark in my basement. So yeah. Okay, well, I think we're all set. One person emailed me. They tried to start at 5. I think they're on the East Coast or something. But
okay.
I think. But no big deal.
Yeah. Yeah, it should be straightforward. I know when I talked to Anna on Tuesday, and just kind of ran through like what was kind of like what we were thinking and stuff. And she was asking how like Bill had presented the week before and stuff. I was like, well, this was more of a lecture. I said, but like if you want it to be more interactive, I mean, I said just in the beginning, just let them know like, they have questions and stuff. And she was going to have like her intern help with like the questions and stuff, like just to have her experience and stuff. So yeah.
Okay.
And we'll make sure my kids. We'll make sure my kids are not anywhere near the.
Oh yeah, my kids are upstairs on their tablets. So
yeah, they're play fighting right now, going hiya and Game Boys. So yeah.
Well, I see somebody from last time because I recognize the screen name. They're signed in under their daughter's name. It's the DARNE.
Okay.
I know who that person is now.
Okay.
Some of those like we'll probably have to remind people to at least put their real name in the chat so we can have that.
Oh yeah.
Maybe we should do that.
Because otherwise, I mean, it's hard because I mean, if it's by phone number, some of them were like I saw the email from maybe saying that with the phone numbers and stuff like we didn't even ask for phone numbers for registration, which I think normally we wouldn't anyways.
Right.
But
well, in one case, one of the phone numbers I called, there were like 3 and I called them. I'm like, oh, why not?
Yeah.
And one of them, it was some company, and the guy's like, I don't know, it could have been any of the 50 people who work here,
Yeah.
All right. Okay. All right. So,
yeah. Well, I mean, one of the feedback that I got was I think people were confused. Some people have reached out to me were confused because like am I registered? Because I didn't get a response back, like an email stating I was registered, and like
they did? Okay.
And so that's where I think like, well, yeah, I'm like, well, it's learning, like it's it makes sense, because people want to like know that I got really officially registered and stuff, right, and times and stuff like that, and Zooms and.
Okay, I'll have to fix that. I thought that was happening, but I guess
no. I think it was just said thank you, and then all of a sudden it was, yeah.
Okay.
I don't know. I like I said, I just had a couple of people were just asked if they were registered and stuff. So I was like, well, yeah, like if you did it, then you're registered. So
yeah, no, that's good to know though. That's something we can fix for the third one and going forward, make sure that's checked off.
Yeah. Because it would be easier because if people are registering last minute, I mean, like it would be nice to have like that, like, hey, thanks for registering. Here's the Zoom link for, like that might be just easier instead of doing it the way we have been.
Right. We could. I mean, I don't mind sending out, the email BCC and everything. It's not a problem, but we could try it the other way.
Yeah, either way, I mean, whatever you feel most comfortable with. It's just something that people have brought up.
Okay. Let's give it a shot for the third. We'll go ahead and I'll make sure that the confirmation email thing is checked, and then we'll include the Zoom link and a little bit more in all the information in that.
Yeah.
I think maybe we haven't done that before because it's a lot of information, but I can see what I can do.
Yeah, I just wonder if people need it for like just verifying, like for employers and stuff, like if they're doing it for something, like they have that confirmation that.
Okay.
I know, like, I mean, I know from Rock County where, like where, I mean, I've had that where I've had to do the registration and if they're getting, yeah.
Right.
So.
Okay. I'll work on that.
Okay.
Get that fixed up.
Yeah, Anna should be in here soon because she said that she had either the counseling appointment that she was, like she was doing the counseling appointment or class or something. I'm not sure, but she said that she would be there. But hers is pretty straightforward. There's no videos or anything and stuff, and she kind of wants it to be more interactive and stuff. So,
right. Echo, turn on Thunderdome. There we go.
Nice. All right, well, I'm going to see if I can get my parents are here too. So I'm going to see if they can get my boys away from the room.
Good luck. Not a good place to sit down here. Yeah, I don't see Anna yet.
Yeah, I know she'll be here.
Okay.
Yeah, I was just going to do a quick announcement about the speaker switching. That's been so I found out in January, early January, that so Bree had gotten, I guess, let go from her job, so she wasn't going to do it, and then the other speaker, so Jan, was going to do it, and then Bree was going to do it because I had contacted somebody else from ASRM that said that they'd be willing. And now we're back to her not doing it and stuff. And Jan just found somebody herself. So.
Okay, so it's Anna who is the.
Yeah.
Okay. Not yet. Oh, Anna Locke?
Yeah.
Okay, let's admit her. Then we'll make her a co-host and we're good to go.
Hello. I look so professional. Can you hear me?
Yeah.
Okay. I got this new mic.
Nice.
But I don't want it to look too, let me see.
You get a Blue Yeti?
Yeah.
I have the same. I have one in gray as well. So.
Oh, cool. Okay. The background hides it.
Yeah.
Good. Good. Okay.
Yeah, we had a total of 157 registrants. So,
wow. That's so exciting. Let's see. Can I change my name on here or am I getting the option edit? No.
You should. I think Garyl's working on it.
Okay. Oh,
yep. Did we make you co-host?
Oh yeah, because I need to share my screen as well. Let me see.
Okay.
Yeah, no. Okay. Hi, Jerry. How are you?
Oh, Jerry? I'll go by that.
Oh, sorry.
That's all right.
I thought Steven called you that. No?
Gerald, yeah.
Gerald, sorry.
Yeah.
My dad had the same name, and people call him Jerry, but I never went by that. But every once in a while I get that. It's not the worst thing I've been called.
Oh.
Let's see. So do you have co-host privileges? I'm just making sure because that it looks like you do. But
Okay.
wait, no, I can't assign it. That's what Stephen, you'll have to assign.
Oh, I got you. All right.
Yeah, I thought I could, but I can't. So.
All right, you should be good.
Okay, let me test it.
Yep. I see.
Your intern was coming as well, wasn't she?
What's that?
I said your intern. Well, I thought, is your intern still coming tonight?
Oh, she should be. Her name is Leah, Lea. Last name starts with a Z.
What was her name again? Sorry.
Lea is first name and last name starts with a Z.
Zeringer?
Yeah.
Okay, I got her.
Okay.
All right.
Hi, Leah. Oh, she got a picture from when she was in Peru and Machu Picchu.
Hello, how are you?
Yeah, I love it. I was there. Hi. Oh, I'm not going to worry about the admitting people. So Leah, thank you for joining. So I told Stephen you would be here and you could help with the chat. So if there's like questions, comments, so that way I don't get distracted by it, you could just let me know. And then you have my links, right, for the Eventbrite, my book, and I think, and then just my website, because I have there like a free PDF that they can download. But that's just on the website, the business website. So what I'll do is like I'll pause throughout the presentation and, take questions or comments and then invite you or just say, oh, well, here's my link for my book in case you want to learn more. So like in various points, we'll put the information there for them. That makes sense. Okay.
I have no worries.
And you can see my screen, right?
Yep, can see your screen. And actually, like I will have to share my screen before we get into yours.
Yes, okay.
So it's like we'll go through that pre-webinar questions and you can just answer them quickly, maybe a little synopsis and then go into yours. So
okay. Sounds good.
It's nice to meet you, Leah, by the way. Thanks for coming.
Thank you. Nice to meet you as well.
Stephen put this all together. He's amazing. He is like an awesome advocate for promoting awareness about infertility. So he's the one who put this together with his school, right?
Yeah, through UW-Madison School of Social Work. So yeah, it's been good so far.
Yeah, we'll have to repeat it.
I think we had about 75 last Monday.
Yeah.
Yeah, I believe so.
Yeah.
That's great.
We start letting them in at 6 o'clock, and then we'll, I'm sure, have some people trickle in.
Mm-hmm.
Yeah, I think so.
That's going to happen.
Check my email, see if we've got any questions. Nope. Looking okay.
So we're going to give this a few more minutes as people kind of trickle in, and then we'll get started in a couple minutes. All right, so I think we'll get started. I'm sure more people will come in as the time goes. So welcome to our second webinar on female perspectives of infertility and mental health. Really appreciate everybody coming today. And first, I just wanted to just acknowledge that the campus of UW-Madison is on Ho-Chunk Native land. And we just want to recognize like the First Nations. UW-Madison really, comes across around the whole state, all four corners. And we just ask that you kind of find out about the land that you're on and to see who is native of that land and learning about their history and culture. So just wanted to acknowledge that, and also Black History Month. Be educating yourself on the topics there. So many of you were at the last one, so this may sound familiar, but for those of you that weren't there on Monday, last Monday, one of the big reasons why I wanted to set up this series is because we do not talk a lot about this topic, like within our education, whether that's in counseling or in social work, psychology. It's just very rarely talked about, yet the prevalence of it is pretty great. And even the psychology, the mental health impact. So my wife and I had struggled with infertility for many years. And fortunately for us, like we were lucky enough to have our twin boys who are almost 3. And just going through that experience, opened my eyes to a whole different world, and just a lack of mental health resources available. And granted that this was pre-COVID, but this was a big reason why I wanted to kind of spread awareness, and with the hope is that if we can increase awareness, one, it's just helpful to increase awareness in general, but also have an idea for future clinicians about what is this like, for people. So a couple announcements though. One, it's being recorded. So once it's done, it will be on the School of Social Work, Sandra Rosenbaum School of Social Work YouTube page. So that way you can access it anytime you want. So I think it should be up probably within the next month or so. And then CEUs, if you're registered, we already have your list. So you'll be getting an email within a week or so, get it with the CEUs and stuff and the certificates. Also, just want to make a quick announcement. Any of you that are going to the webinar on the 23rd regarding third-party reproduction, our speaker has changed. So instead of Bree McKellar, it's going to be Chris Rodert, still from the same place, Wisconsin Fertility Institute, but Bree is not able to speak at this webinar on the 23rd. So I just wanted to give everybody a heads up in case you went there and all of a sudden you're just like, wait, who is this? So also just make sure mentioning if you're using your phone, using your first name, just putting your real name in the chat at the end so that way we can verify CEUs in your attendance. So we just had a little bit of difficulty in the last one. So without further ado, I would love to introduce our speaker for tonight. So Dr. Anna Flores-Locke is an international award-winning author and educator who has worked in the mental health profession for more than 15 years. She holds a doctorate in counseling and is a licensed professional counselor in New York, New Jersey, Illinois, and Puerto Rico. She currently owns Sherlandra Counseling Services, a virtual infertility counseling center, and is an assistant professor at Nyack College. Dr. Ann is an active leader in the American Counseling Association and the author of Body Betrayal, Understanding and Living with Infertility, and Introduction to 21st Century Counseling, a Multicultural and Social Justice Perspective. From her personal and clinical experience with infertility, Dr. Anna created the fertility clarity approach to infertility counseling. She is a Latina twin mom from Chicago and currently lives in New Jersey and enjoys dancing and going to the beach. So here's Dr. Anna.
Thank you, Stephen. Thank you so much for that warm introduction and for putting together this webinar. And it warms my heart that all of you are here because Stephen and I really connect, not only because we have personal stories with infertility, but because we are also leaders in the field who want to advocate and build awareness. And so because you're here, that's showing me so much love and care that you have for this delicate, intimate, invisible mental health concern and reproductive health and physical and emotional. And we'll get into how intricate and involved having infertility and struggling to conceive is. So before we get started, I see some cameras on, some not yet, but if you can, I want you to do a little exercise with me. So you want to put your cameras on and put your hands up, all 10 fingers. There you go. I see Tash, I see Leah, Sarah, Landon. Thank you, Sarah. Another Sarah, Megan, Lynn. All right, Amanda. Look at those beautiful faces. Love them. Jenny and Nicole and Donna. All right, now I can feel the energy. Okay, so now what I want you to do is count to 8. And when you take, let's do it this way. Have your fingers up and we're going to count. And each number, you're going to put the finger down until I tell you to stop. Let's see. No, let's start with 8 fingers. 7, 8, there we go. All right, now we're going to count down 7. Ready? And each number you put down a finger. You're going to 1, 2, 3, 4, 5, 6, 7. Good. 1 finger. Now look around the room. 1 in 8 couples have infertility. So imagine you had 8 fingers, we put down 7, 1. And now if we count however many fingers are left in this room, that's a lot of people within just this group. So that's what I want you to hold on to as we continue this conversation, is that even though infertility and struggling to conceive is one of these silent, invisible things that 1 in 8 at least experience this crisis. Which also means many of us in this room have this situation or know somebody as well, right? Which makes it even more needed and powerful to talk about the female perspective on infertility and mental health. And so we did the 1 in 8 exercise to really amplify the prevalence of this medical disease and condition. And also, since we're focusing on the female aspect, about 30% of infertility is caused by female factors, if you will, right? 30% male, which was talked about last time, and then you have kind of this 30% unexplained. So I like to also share that statistic because part of the female experience is that we tend to be the one blamed the most, because we become the identified patient, right? We're the one in the doctor's office getting probed, checked, blood work. I mean, the intensive testing that happens when you go to a doctor and your gynecologist and you tell them, I've been trying to conceive. And they ask, well, how long have you been trying? And you say, maybe 6 months. Okay, then they ask you your age and you say, oh, I'm 25. And they might say, okay, well, try for another 6 months and then come back and we'll talk. Because according to the definition for infertility, there has to be 12 months of unprotected sexual intercourse to qualify without a pregnancy to qualify for infertility. Now that's age dependent, okay? Because the older we get, the more fertility drops. So when you're older, I think it's like 35 or up. Now, instead of 1 year, it's down to 6 months. And if you're in your 40s, it's more like 3 months because they want to take action quicker. So you go to your gynecologist, you tell them, what's going on. They put you through a battery of tests. If you're with a partner who's a male partner, they have to give a semen analysis and that gets tested. And for the most part, for some men, that's the extent of the testing, I think, right, Stephen? That's kind of.
Yeah, for the most part, I mean, there's some like genetic and hormone, they get your blood work and make sure hormones, but yeah, it's definitely more tests and stuff for females.
Right. So for females, we have to go through a lot more, right? Because if you think about even just reproductive system in general, when it works properly, like there's so many parts of it that have to work, right? Your ovary has to release an egg. It has to go through an open, clear fallopian tube, travel down the uterus, get fertilized by a sperm, implant itself in the uterus that's nicely lined with, the nutrients an embryo needs to grow. The embryo needs to grow in that lining. So there's like a lot of things, right? I see Nash is like, yeah, nodding her head. So even in women and couples that don't struggle to conceive, the chances of getting pregnant are still only like 20%. Right. So now on top of it, you have either a female factor, a male factor, or both, as was my story, or unexplained. So you can imagine now, right? I'm at my gynecologist office. I've been married for 3 years. We haven't conceived. And, they state now, so my struggle, my personal story was, my husband and I struggled for 3 years. And for the first 2 years, him and I just constantly fought because to my husband, he's like, just wait, it'll happen. It's nothing wrong. And I'm like, no, we need help. Like there is something wrong. Month after month, get my period and there was no pregnancy, right? So finally by year 3, he came around and we sought medical treatment. So, and I shared, and so now I know, so well, I'll get to that later. So then we get medical treatment. And so first there's these 3 years of like just trying and facing sadness and disappointment, feeling inadequate, right? Because month after month, somehow my body is not working like it should. And for most of us women, we're socialized to take the blame, to say, there must be something wrong with me. It's not my husband. It's not, I don't know, right? I mean, for me, at least, I internalize that blame. So now I'm not only feeling inadequate as a woman, I'm disappointed and sad because every month I'm not pregnant, but I feel guilty because now I'm not providing my husband a child. Right? And for me, as a Latina woman, like being Latina and Catholic means you get married, your job is to provide children. Now, mind you, at this point, I own a business. I have a PhD. I'm a professor. None of that's inconsequential to my family, especially my dad and mom, because in our culture, having a child is what is most important. So now I'm feeling guilty. Not only am I failing my husband, I'm failing my parents. His parents were not so, they had 4 other grandkids already and they were not so putting pressure on us. But my family had no grandkids yet. So it was me. It was up to me. But, guilty too, because now when we try to make sense of what's going on with our inability to get pregnant, what we tend to do is go into our own history and start saying, okay, did I make bad choices in my sexual behavior that caused this condition? Am I being punished by God for some reason because I did something wrong. Like I'm a good Catholic girl. Shouldn't I be blessed? Shouldn't my prayers be answered? Shouldn't I just be getting pregnant? And all these questions start happening. And it's chronic and persistent, right? This is the one thing with infertility that it never ends. Not only is it in the beginning when you're trying to conceive, but then after I conceived and we did IVF and we got pregnant, now I have an IVF pregnancy, which puts you into this different category of risk medically. But then my twins are 9 years old now, but I still have shame about not being able to get pregnant. You know, I always had this hope or fantasy that we would somehow get pregnant naturally, and it still doesn't happen, right? And then there's grief not only in not being able to get pregnant, but there's grief associated to this sense of my identity as a woman is missing fertility, right? Is missing this part that I grew up thinking defined me as a woman, right? I mean, most of us in our society try to prevent pregnancy, right? We are like we're all about, preventing pregnancy until you want to get pregnant, and we postpone because we want to have our careers and do those things. And so there's also that sense of grief that, my body's failing me somehow. I'm not a true woman. So I'll stop there for any comments, questions. Okay. I'll take a deep breath, because talking about it brings up my emotions. Emotions don't go away. We just learn to integrate them into our lives and live with it. So we talked about emotional aspects from the individual perspective, right? There's also social and relational implications to having infertility, right? One is, and this is big because most of us, when we are starting to build a family, most of our friends are also having kids, right? And building families. So now, you know how it's like, I don't know, for me, it's like if you get a new car, like all of a sudden everywhere you see your car, right? You're like, there's that car, there's my car, right? Like you see it everywhere. The same with pregnancy, right? Once you want to get pregnant and have a baby, like everywhere and everything is baby, pregnancy, another alert, another gender reveal. Oh my God, I'm sick of this, right? Like get out of my face. Right? Because it's also very socially reinforced, especially in most of our age groups, right? It's you have a family, you have a baby, and so it is celebrated. It's always just something in commercials, TV shows, on social media. So you're always facing this while you're trying to conceive. And now you're suffering in silence because of our emotional place of feeling shame, guilt, embarrassment. We isolate, we don't tell our friends, right? So now you're facing like, okay, I got another invitation to a baby shower. I don't want to go look at baby stuff. I don't want to shop for a baby gift. I don't want to go to a baby shower because I look at her and I want to be her. I want to be the one pregnant. And she's pregnant. So you got to face that. You got to figure out for yourself, am I going to go to that? Am I not going to go? Something that a friend of mine who's on the call here, she shared with me was creating a script, right? So having a script ready so you have an answer. And so when you go to if you decide to go to the baby shower and somebody comes to you and said, oh, I hope next month we can celebrate you, or pretty soon that'll be you with the baby, And inside you're shattered. You're already shattered. You're going to this place already in a fragile state. Then you hear a comment that I call reproductive microaggressions, right? Some of you who are in social work and doing cultural humility training know what a microaggression is. Now there's reproductive microaggressions, right? Those little comments that are not, intentionally meant to hurt, but they hurt, right? When someone says, what's taking so long? I used to hear this a lot, like, it only takes 5 minutes. It only takes 5 minutes for your husband to do his business inside of you, and that's all you need, right, to get pregnant. Or just relax. That's a big one. And if some of you have heard reproductive microaggressions, please, put them in the chat and share with us what you have heard. And it doesn't have to be your personal experience, but maybe you've overheard it. And maybe, we do it. I've done it in the past too, right? I mean, that's part of building your cultural competence, is knowing, oh yeah, I've done that before. And that's all you knew, right? Like I grew up with that. Someone's married. Oh, when are you having a kid? And maybe it's 2 years after their marriage, So we face reproductive microaggressions. We have to, now, one caveat to like figuring out, am I going to go to this other baby shower, is your cultural expectations. Because I know for me, being Latina, it's when there's a family event, it's not really a choice to not go. Right, Taz? Yeah, I see and if any of you relate to that, give me a little emoji. I know you have the little reactions. Right, so you can't I didn't feel like I could not go, right? It was a family event, you got to go. And so I dragged myself to go, I'd go, but I would have like Lynn, she's on the call from Kindred Beginnings. She, talks about creating a script. So what are you going to say when you have that reaction from somebody? And so maybe it's, yeah, I'm trying. Thank you. Thank you for your concern. We're talking to a doctor about it. Or thank you for your concern. I'm going to go get some chips. Or, that's private. I prefer not to talk about it, right? But there's some kind of respectful statement that you have ready, so you feel empowered. So you're not at this event like, a deer in the headlights with no response, and you're just hurting inside. And also, what I tell my clients too, as they're going through navigating social and relational situations, is to give yourself permission to take your breaks. Right? So it's fine. You go to the event and you say, oh, I'm going to take my drink and I'm just going to go out to the porch for a little bit. Or I'm going to go to the restroom, the one that's like upstairs, far from people, and stay in the restroom for 10 minutes and cry your eyes out if you need to, and then come back. Right? So give yourself permission to have those breaks and those pauses, because you need it. You really need it. Okay.
So we have a question in the chat, and
yeah.
And the question is, it says, do you share your experience with your clients?
Oh, and what exactly?
Like with counseling and stuff.
Okay.
Sorry, yeah, I don't know. Your individual clients do share your experience, your challenge. But that's might be another topic. Sorry, I just thought.
No, it's okay. Sure. So actually, Leah, she's my intern, so she's helping me during our presentation. So she's going to put in the chat a link for my book. So I wrote my whole story in this book, and so you're more than welcome to check it out. It's also on Amazon. So if you have Kindle, you can get it for free and or download it from Amazon. But because my passion and my life's purpose is to help people struggling to conceive and with infertility, I am authentic and genuine with them about my story. Now, because I'm also clinically minded and I'm trained in knowing the timing of things, I also know what to share and what not to share depending on their situation. Right. So like somebody who is struggling to conceive is not ready to hear that I succeeded and had twins. Right. So maybe that's a part of my story I don't share yet. I stay with, this was my struggle. I understand the IVF. I remember getting injections. I remember my ovaries being so swollen that I hurt. Like, I didn't know your ovaries can hurt, but they can hurt. So yes, I do, Tash, because I really believe in that personal connection. And that is the one thing that my clients tell me, that, you know, they found me and they work with me because I have a personal experience in infertility. And there's this automatic like sisterhood. Like once you meet somebody else who's struggling, like you get it. And it's something beyond empathy, right? It's just like this, you can only understand it if you go through it. So I definitely do, Tash. Yeah. Thank you for your question. Yeah. So any others? No? Okay.
There was this one, I guess, like there was lots of comments about microaggressions, but there was one that said it seems like shame is more internalized rather than guilt. I think when you were talking about like the guilt of not having to be able to give your husband a child.
So shame is more internalized. So yeah, shame is more like blaming yourself and feeling ashamed because you're failing, right? And guilty, for me, feeling guilty was more because I was failing someone else. So I guess, yeah, I could see that distinction a little bit from that comment. Yeah, thank you for that. So speaking of guilt for failing in my role as a wife, the effects on the couple. Because infertility is a couple's issue most of the time. And we'll talk about other considerations when it's not. However, this is, you know, a typical straight couple trying to conceive, and or it could be same-sex couple, because the struggle is the same in both. But we'll talk about the differences later. But the effects on the couple, right, is that like in my story, it was the fighting, the blaming. I call it the blame game in the bedroom. So first it was me blaming myself, then I started blaming him. Then it was like, you drink too much diet soda, you're not keeping your blood sugar. I don't know, Amanda, right? When you're desperate, you believe anything, you know? So in my head, I was like, it's the diet soda, you're poisoning your body, you're making the sperm not good. He has type 1 diabetes. So there was a time when it wasn't diagnosed. So I was like, you ruined your sperm because your blood sugar was too high. And, you know, anything, because I was desperate, right? And when you're in desperation, you say things you don't mean, and you just try to blame so that I felt less guilty or less ashamed, right? I try to make it my husband's fault. And of course, that just negatively impacts the intimacy and communication. Because now, as Stephen or other men in the room or from last week's seminar can share, the men start to feel like they're just needed for sperm. I didn't care about anything else but sperm. That's what my husband's function. And when you're going through fertility, you start charting your fertility window. You know, there's apps that help you. There's like test kits for your ovulation time, you know. And so now it's like, time is now. It might be 2 p.m. and you're working. I'm going to go in my car and I'm traveling to your job and we're having sex because now I am fertile. And I almost traveled with my husband to Kentucky because we were going to be in a fertile window. All right, this is how drastic our behaviors become when we are super, super focused on trying to get pregnant. So of course, I mean, how sexy is that for either of you? Like, let's just have sex because we're fertile now and we got to do this like every day for 4 days to get pregnant. It's not. So your intimacy most likely is going to suffer. There's no more, romance. There's no more enjoyment. It just becomes a chore. So that's one big factor that, when I do talk with couples, I'm very much into prevention now, right? And since I went through this experience and I know the research on this topic, I talk to them about their intimacy and try to really encourage them to have sex for fun and not for procreation, right? To try to engage with one another and also in other intimate ways. It doesn't have to be sex. There's other ways to be intimate, but that you can keep that spark alive in your relationship because you need each other in this process. Communication suffers too, because usually, and like I said, there's always exceptions, but usually the woman, shares her emotion and says, I'm sad, I'm upset, I'm so disappointed. And the man just goes into problem solving. It's okay, we'll see another doctor. We'll go, what do you need me to do? I'll go get the, another one I think was nasal decongestion. If you take that, it improves your fertility somehow, or I think it's your mucus in your reproductive area. Who knows, right? There's a lot of different techniques. So anyways, right? Do you need me to go get that pill? Do you need me to do this? And you're sitting there just I just want to cry and I just want you to hug me. I don't need you to problem solve. But sometimes that's what the couple does. And then there's a disengagement in their communication. And then that becomes a cycle. So now you're not having healthy, productive, positive sex with one another. You're not communicating with one another in a beneficial way. So you can see how the relationship really starts to suffer. And unfortunately, some marriages don't make it through. They end up divorcing. And, a caveat to this with, again, the cultural piece, I have a colleague who's Latino, and there was a male factor involved with their fertility. And he almost got to the point of saying, I will divorce my wife so she could find a man who can give her a child. And Stephen agreed with that.
I can definitely relate to it because I said the same exact thing and have thought the same exact thing.
Mm-hmm.
Because you internalize that guilt and you just want them to be, this is not the life you imagined.
Yeah. Mm-hmm. Right. So, that was powerful for me to hear. And how much having a baby means in a marriage or in a partnership. Right? So now we also have situations where people do get pregnant and they miscarry or they have stillborns. And that's part of the fertility journey, right? There are many people who struggle with fertility, can conceive, but can't carry a baby to term. And so that's an added stressor, not only on the woman, but also on the couple. Right. And I put grief here, but if we think about this too, as in layers, right? At the top layer is the grief of I can't conceive or I can't carry a baby to term. I'm infertile. I'm defective. Then if you have miscarriage or stillborn, you have this other layer underneath, which is I'm grieving the loss of the baby that I did conceive, who was not born. And what makes this so unique in our story is that right now, and things are happening to change this, but right now there isn't really a social ritual to acknowledge the loss of a pregnancy, to give closure for that. Right? So usually, and what I mean by that is there isn't a funeral, right? There isn't usually we experience a death and there's a person to bury and you have a funeral or an event. You grieve in your community, with your community. With miscarriage, you don't have that. So now you're alone or with your couple who you're fighting with, your partner. You both are grieving this loss, but you feel so alone in it because another reproductive microaggression that people might say is, oh, it's, just get over it. You could get pregnant again, as if that fetus was insignificant, right? Was not a life, was not your unborn child. So that's another layer that really complicates this journey for couples and for women. Any comments or thoughts on that? That one's
I was even going to add about, like, it's even when transfers fail, like when they put the embryo back in for IVF, like that's even
yes, thank
a
you,
difficult
Stephen.
thing.
Thank you, Stephen. That's right. I didn't put that on my slide, so I forgot. Yes. So not only is there, if you do get pregnant, a miscarriage or stillborn, and you have a loss of that unborn child, there's also the loss of what that child meant. Right. So you also had this future fantasy. I'm going to be a mom. I'm finally going to have my baby shower. I'm going to succeed in being a wife and a daughter and give a child to my family. And all of that is now lost as well. Right. So you're grieving the unborn child and you're grieving that future, what that child meant. Now, the other component that Stephen brings up is when you're in the fertility journey and you're doing either in IUI, intrauterine insemination, IVF, intra vitro fertilization, but you're doing some kind of medical procedure to get pregnant. You know when that is happening. You're counting down those 2-week wait to see if you're pregnant. And then you hear the news you're not. That is another loss. It's a loss of that cycle, right? It's a loss of that egg and sperm or embryo if one was implanted. And even that causes grief as well, right? And so you could see again how this is chronic, persistent, compounds, right? Because month after month, you have a failed cycle. And every time that happens, there's grief, loss, sadness, disappointment. So you have 12 months, 24 months, 48 months of unresolved emotions. Right? Can you imagine? Well, I know what it felt like. And talking about it, I still feel it. Writing my book helped me heal because I was finally able to get it out and share my story. But the other aspect to this, how I conceptualize this too, and I know Stephen and I have talked about this aspect of going through this journey, having these losses, going through the medical treatments, the trauma on your body does cause post-traumatic stress. And there's a book out there, I saw it, but there is research to describe the experience and effects of infertility is like having cancer, is like going through post-traumatic stress.
It was Ellie Domar in 1993 that compared the psychological distress between, it was cancer, I think people experience heart attacks or diagnosed with cancer, HIV, and then there was one other thing. And I know that infertility and cancer, there was no significant difference. Mm-hmm. And they're basically meaning they're essentially the same psychological distress as getting diagnosed with cancer.
Mm-hmm. Thank you, Stephen. Yeah. So this is why we do this work. And I'm so happy you're all here to share in this work with us, to support us. And so to speak to the LGBTQ plus considerations, I also work with same-sex couples and single parents by choice, right? So women, right now I only work with women, but men can do it too. But, somebody trying to conceive. And for same-sex couples, what I hear is that, they're clumped as part of this infertility community, but they may not have infertility. Biologically, reproductive system may be working fine. It's just they don't have the reproductive part, right? They're missing the sperm or they're missing the egg. It's not that they're infertile. So that's part of this experience too, that for same-sex couples can be a little confusing, because it's like they have to engage in like reproductive medicine because they need to use donor egg and donor sperm, but they're not infertile, right? So they're kind of in this gray area. Where do they belong in this whole thing? And I have support groups too. So I have a support group for same-sex couples because they expressed that need to me when I met with them. And so we have support groups for them as well. So mental health interventions, I mentioned some strategies, right? Having a script, taking a pause, taking a break, and also really looking at a holistic approach, right? So because like Stephen said, the psychological distress is so high, we have to take a stress reduction approach, and we have to treat the body as much as we have to treat the mind and the emotions and the psychology. And because it's so pervasive, one thing that fertility doctors tell me as a helping professional is like, we can get people pregnant. I just need them to stay in the game. I just need them to keep coming back, because this is so tiring that if you've been trying for 4 years, 5 years, 10 cycles of IVF, like your money runs out. First of all, it's expensive. And second of all, you just don't have the energy and stamina to do it anymore. So you quit. Right. So part of my mental health intervention is to keep their stamina, keep them going so they can get to their goal, just to have a baby. And so that's kind of what fertility clarity is based on. Like, we can take a holistic approach. I apply the acceptance and commitment therapy strategies, which is very mindfulness based, very looking at it from the perspective of like, I can't take away the pain you're experiencing, but I can help you manage it. I can help you ride the emotional roller coaster, which is what this is often called, in a way where you are not losing yourself in the process, in a way that you can still find joy in life and still engage in the life that you value, to build your psychological flexibility. So that's that's our goal with that approach. So in the chat, Leah can also put up, I have 5 reasons you need infertility counseling now. It's a free PDF file you can download from my website. And then I am hosting monthly free clinically guided conversations. And the first one we're going to have is March 7th. And it's going to focus on how infertility affects our relationship to God. And I talked a little bit about it, but the experience of blaming God or asking God and praying about it, and then your prayers are not answered. So I'm going to host that conversation so people can have that safe and courageous space to talk about their relationship to God and infertility. So that you will find in the chat, and I'll stop sharing and engage with you guys. So thank you, Leah, for putting those in there. All right, I'm all yours. Any reactions to what you heard? Any questions?
Feel free to popcorn share, like if you want to speak or just say or ask a question or have a comment.
Yeah, and show me your face. I love all your wonderful faces.
I can share something.
Thank you, Amanda. Yeah.
Yeah, of course. So, I'm 22. I'm still in college. So I'm pretty young. So I'm in the phase of like, people are starting to get pregnant and starting to get married. And I've never wanted marriage and I've never wanted kids. So that's why I thought it was a good idea to come to this, because I don't have that experience, and knowing that the experience exists, I thought was going to be really beneficial to me. But just reading all of these microaggressions and hearing about how it's like diminishing to the human spirit that all of this is. It's so hard to read, and just I don't get to experience it with you guys, but I'm so sorry that all of you have gone through this.
Well, thank you, Amanda. I'm blessed that you came for the awareness, because that's the purpose of this, because now you're an ally, right? You're a support for us. And chances are one of your friends will struggle, right? And now you can actually, one of the kind of interventions too from the community is you can, instead of doing microaggressions, of course, now that you know that, or if you do, because like I said, we all do, you apologize, right? You say, I'm sorry, that was insensitive of me. I'm here for you. I'm here to listen. So opening that door and saying things like, I've noticed, I know you've been trying to have a baby for a while. Are you having some trouble? Like, what's going on? I'm here to talk to you. Or how can I help? And maybe you could be that person who can find them resources, right? Find them a reproductive doctor, find them a support group, find them, and there's a lot online now too for support.
Okay, so, I have to go to bed now.
Thank you, Amanda, for sharing.
Baba, we have to go to bed.
Hi.
Yeah, Ashton. Hi.
Hi. So I thank you for this. This is wonderful.
You're welcome.
I'm a child provider. I'm not a fertility provider, but it's something that sometimes parents bring up. Just because parents do sometimes, and I go, I can recommend someone. But it's important. That I deal with fertility. That's one of the main reasons I'm here as well. But this is an important topic, and something that once I saw and signed up for this, I actually am starting IVF. Actually, my first round is of this upcoming month, in March.
Good luck.
So that's exciting. But I actually brought it up as a positive in a clinical care group, just a personal positive of I'm starting IVF, which was a big step to have that, even though it's been a hard journey. And the fact that I need it stinks, obviously. It's a positive that it's happening. And so that's something just to share for anybody who is doing that and having to be part of it, to try to adjust some of the thinking a little bit as much as possible, because 4 years is a long time. So, it is what it is.
Time. Thank you so much for your vulnerability, Ashton, and for really your testimony opens the door on this conversation. And that is so transformative and so powerful, because like we did in the beginning, right? 8 fingers, put down 7, one person that or in this group is struggling. Now that person has connected with you, Ashton, because now there's somebody else in the room who is struggling too. And I'm not abnormal and different and alone in this. And I no longer have to be silent in my suffering. Now I can share with that purpose of building connection and community so that it's not stigmatized anymore. Yeah. Thank you, Ashton. Yeah.
Wonderful. Thank you.
You're welcome. And another thing Amanda made me think about being a young person, or your age group, is also an aspect of fertility. And I actually, with clients who are in your age group who come in for anxiety or depression, sometimes they do have like PCOS or endometriosis, like there's reproductive concerns, and they don't want to have kids yet, but we talk about it. And I say, look, like that's something to really talk to your doctor about. And if they dismiss you because they're like, oh, you're young, you don't want to have kids yet, then I'll find you a different doctor, because there's options. I mean, you can do egg retrievals when you're young, and you can freeze them for later use. So you have good young eggs to use later. So there's things that can happen when you're younger if there is already like indications of some reproductive health concerns that can really help you have a child in the future. And that's something also that's not talked about, right? Like in our, sex education, they don't talk about any of those things, So again, it's helpful just to know. And then if you are counseling someone, to broach that topic, to make that part of the conversation. Yeah, Maddie? Oh, sorry, Jennifer. Go ahead, Maddie, and then Jennifer.
Okay. Hi. I just was gonna bring up one other thing that you may have said and I missed it, but that I think a lot of men and women dealing with infertility, but particularly women deal with, especially ones that are in health sectors, like I'm a nurse. I think we deal with a lot of issues with people sort of talking down to us, questioning our kind of knowledge of our own health and body and wellness and things. And just from my personal experience working with therapists through my process, I think that's something really important to highlight, because there's many a time where, I feel like I've said to a therapist, I'm sure everybody thinks I'm crazy because I keep pushing and pushing and pushing and, saying something isn't right. And, it has come with very dire consequences, unfortunately, in my situation, because people didn't listen to me. And so it's just something to be mindful of as you're counseling clients, that's a very real and unfortunate piece of healthcare.
Yeah, thank you, Maddie. Thank you, Maddie. And it's very sad and unfortunate. And yes, you have to be strong and you have to advocate, and it's okay to be a pain. It's your body. It's your life, not theirs. So keep at it. I think Jennifer.
Hi. Yeah, sorry I jumped on late. I was actually on the phone with my fertility doctor. I found out I just did a retrieval and I found out I got one healthy embryo.
Oh, congratulations.
From I had 10 eggs retrieved. Now I'm 41. I'm actually going the solo route. So I started with IUIs. I did 6 IUIs with a clinic, and they didn't want to look into anything at all, like why the IUIs weren't working, this and that. So I switched clinics, and I had to get the endometrial. I went and got the laparoscopic surgery to check for the endometriosis, and I had stage 2, and I also had some fibroids, and I also have a blocked tube. So definitely advocate for yourself. Ask questions. If you feel in your gut that you're just, the clinic's not for you, definitely switch. I live in Jersey, and I was going to a clinic in Jersey, and I switched to Manhattan because I got, it was a referral. And I'm so much happier. It is a little bit more stressful, obviously, going to the morning appointments. I have to make sure I'm there very early and stuff like that, but I'm very happy with them. I actually don't talk to the nurses. I actually talk to my doctor all the time. He's so hands-on with everything, and I really like that. So so that's just something that I've found with my experience. Sorry.
Yeah, that's okay.
With my experience, with what I've been going through. And also, I wish I learned about our eggs and how they ate and all that stuff when I was younger, because I would have done this. I've been since I was 32. I would have done it a lot sooner.
Yeah. A lot of people live with, you did the best you could. And I know people live with that regret. All you need is one.
Right,
all you need is one.
Right. We're going to one more. I'm going to try one more retrieval because he wants to go with 2 or 3 at least. So,
okay.
So fingers crossed.
Yes. Fingers crossed. Yeah, you're welcome. Thank you for sharing, Jennifer.
So I will attest that my wife and I had gone through 3 clinics before we ended up, we ended up the 3rd one, in Missouri. And the first one wanted to do some sort of surgery on me. And I'm like, I want to get a second opinion on this, because it was not covered, So we went to a second opinion, and the guy looked up, the urologist looked up the surgery on Wikipedia. of all things. So not very scientific. Well, he did connect me to a great doctor in Milwaukee, and apologize for my kids screaming in the back. But yeah, I mean, we definitely, we were going to Milwaukee, and then all of a sudden my wife's insurance changed, and then that didn't happen. And then we ended up doing in St. Louis. So yeah, you definitely have to kind of shop around a little bit. So your professional hoop jumper is what I called myself at that point. So I wanted to share a comment, so Jan said, one issue that's not always talked about is the solutions to infertility barriers are expensive and sometimes very expensive. Surrogacy, for example, is that poor women and lower income women can't resolve their hopes to have a baby due to economic barriers as well. So
yeah,
the huge thing for me is just, I mean, because I think it's 19 states now, so it's better, but I mean, it's still 19 states out of 50 that have mandated fertility coverage for insurance.
Yeah. Yeah. I mean, and I saw resolve.org came up. Resolve is a big advocacy group that is working at the national level, right, to get laws, to get insurance coverage. And I mean, there are grants, there's some funding. But you're right. It's a class issue, right? It's a social class issue that infertility treatments is only for a certain socioeconomic class. Yeah, you can only access it if you have the money or the insurance coverage. And so that is a reality. It's a sad reality right now. And that's why, I mean, there's crazy stories of people find ways to get pregnant. There's black market sperm, there's a documentary on it about meeting people in hotel rooms, a man to come and impregnate you and not tell your husband, so you could just get their sperm. And there's you could find these people on websites and stuff, so it's again, going back to that desperation of, if you can't access the care, you go to these other routes that can be very dangerous. But thank you, Donna. So thank you again. Leah has put up the links to stay connected. Please join me for my clinically guided conversation on March 7th at 7 p.m. And also on my website, there's a free PDF for you to download and to stay connected. And in this group, you've already formed community. So connect with one another, stay connected with me. And some of my events for the conversation online, that's open to that's a national event. So it's open to anybody, anywhere, even though I'm in New Jersey right now. So thank you again, Stephen, for having me. And thank you all for sharing as well.
Yeah, appreciate everybody coming. I did post a link. There's a post survey. It would greatly appreciate it if you guys take that. It actually helps with my schooling, since I'm in my second of 4 years in my master's social work program. And then I've also included my email there within the chat as well. You can find it there too if anybody has any questions or anything else. I've done a number of podcasts. One is out. 3 are still pending upload, which drives me nuts because I hate waiting. I want them to be out now. But it's definitely something that we just need to increase awareness, and this hopefully, this to help people out, but also maybe even increase the amount of providers. It would be great to literally have somebody that has some experience with this in every local clinic, so people don't have to travel, so far in order to get the access to mental health. So.
And Stephen, I'll send you the PowerPoint because I don't think I can upload it on the chat, right? I don't see an option for that.
Probably not. So we'll send it out. So if you email it to me, I will make sure Carol, our events person, will send out that within the next week or so.
And Dr. Natasha, now I see your full name. Were you at the ASRM conference?
No, I haven't been to it yet. I'm going.
Okay, I thought maybe I saw you there. Okay.
Oh, my mom, Dr. Vesna Radojevic, maybe.
Okay. Yes. Okay, cool. Is she in New York?
We're in California, San Diego.
Okay, no, I think she's in New York. No, she was in Chicago, actually. Okay, never mind. anyways, it's a small world when you get into the infertility world. Yes. Right.
There's only so much of us.
Yeah, I know. Small group of us.
There was one question. If you want to do one last question.
Sure.
It says, are there telehealth implications for suitable infertility treatment?
Great question, Gabriel. I do telehealth. So because I'm licensed in multiple states, I do telehealth, even in New Jersey, because people cannot come to my office. So for mental health, yes, I could do telehealth. For medical treatment, I mean, what people can do actually is you could have you could do kind of hybrid. So you could find a location near you to do like the monitoring, the blood work, ultrasounds, like locally. But then your treating doctor, your fertility doctor might be somewhere else, and you might meet with them through telehealth. So there are options to kind of do a hybrid approach if you want to do something like that.
Even before COVID, and we went to outside of St. Louis, and it was 5 hours drive. So a lot of the blood work that my wife had to do was done locally. And then there was only like once or 2 weeks, 2 days out of the month, like we had to actually go down and meet with the doctor and stuff, which may be different now because of COVID. But even then they were making sure you had, could do some stuff locally so you weren't taking as much time to travel.
Yeah, and I'm not sure what remote delivery means. If you mean like delivery of a baby or remote delivery of what? I'm not clear on your question, Gabriel. Oh, remote, like of medicine? Well, yeah, I mean, the medicines can be mailed. Is that what you mean?
Yeah.
Yeah.
So, if you think about like the shots and stuff that you take for like IVF and stuff like that, a lot of that's overnight mailed. I remember we went through a clinic or a pharmacy in Arizona, and we had our meds the next day.
Yeah, I've had people who will fly to Mexico, get the medications they need, and bring it home because it's cheaper. Now, some of this is like they needed like Humira, for example, because they had kind of an autoimmune issue affecting the pregnancy or something. So sometimes it's like these other medications, not just fertility medication, but they'll go to Mexico, pick it up.
That's why I'm like, there's so many layers of infertility and just fertility in general, like that it could be an entire class. Because I think about people that go to like Prague and some of the other countries to do IVF because it is cheaper. So you think about travel, and all that, and like I also think about like fertility preservation, right? I mean, for trans, youth, and just transgender people in general, and people that have had, oncology or cancer, childhood cancer. There's just so many layers to it.
Mm-hmm. Yeah. Good point, Stephen. Yeah, we're in an exciting time, I think, because even in the 10 years that I've been involved, like there's just been so much progress and so many new things that I'm learning that it's amazing. It's amazing, the technology, the ability we have, the support systems in place now, the involvement we have from people like you who are advocating and talking about infertility and helping others. To me, it's exciting that way because now we're not isolated anymore and we can get help and support.
Well, like you said, it's a new field. I mean, it's really been 1980, 1979, I think was the first one in the UK. Mm-hmm. But it's really a new and emerging field. So
yeah. And so Gabriel's at the American Society of Reproductive Medicine is kind of like the home of reproductive medicine, but there's a mental health professionals group within there. And so there is a lot of collaboration between mental health support providers and medical doctors, because medical doctors do understand the psychological effects of infertility. And so another service I provide is when someone wants donor egg or donor sperm, they have to have an evaluation with a helping professional. So they meet with me, we have a conversation about what does this mean? What's the ethical, legal, emotional, psychological implications of using donor egg or donor sperm. And so the doctors won't proceed until that evaluation is done. So there is a lot of collaboration to where fertility treatment, there's different points in that treatment where a helping professional needs to be involved for that patient to proceed and move forward. So in that regard, it's very interdisciplinary and collaborative, definitely.
And some clinics actually have mental health embedded in their clinics and stuff, and there's some that don't. And so, and I think there's debate on whether one it should be one or the other. But people on both sides have their great points, honestly. Like, because I initially thought that we should all be embedded, but then there's also privacy issue, like in HIPAA, and are they going to be more forthcoming with information if you're connected to a clinic compared to being an external, neutral party outside of the clinic? They may be able to share more information about their mental health. Because I know something that's, at least for me, at least, was I think there's a concern if you share to your doctor about your mental health that they're going to stop your cycle and they're going to just slow it down, and you're so in panic mode, and drastically, you're not going to tell your doctor, anything that would remotely, stop the process and stuff. So,
yeah, that's a common fear. Yeah. And I do have to kind of ease that with people when I talk to them. I'm like, I'm not, I'm not evaluating you on your fitness, your psychological fitness to be a parent or anything like that. This is more for informed consent, that you really understand what this means. And sometimes you do have to pause, right? Sometimes maybe right now you don't proceed, and we talk some more until you get to a place of okay, I can make peace with this. I'm okay with this. Now let's do it. But you're right. There is that misconception that I'm going to be told I can't do it or something like that. Yeah. So, okay. Thank you for staying over as well. I really love our conversations. And again, I hope to see you on March 7th. And if you need to connect, please, you have my website, and here's my email. Sorry, as well. I mean, you could get me through my website, but that's my email as well. So we can connect. I would love to be part of your community. And everyone, have a good night.
All right, have a good night. And please, like I said, if you could do the post survey, that'd be greatly appreciated. So, and I appreciate everybody coming, and have a good rest of your evening.